and step up for presenting on various topics, as it will open doors to limitless benefits.
So, join us in studying together as a team and help us to raise this platform to the next level. Journey to be the better doctors, the Grey Medicos. Thank you very much.
Thank you so much for playing the video. A warm good afternoon, everyone. Today, we are here again joining in order to learn and grow together with a platform known as Grey Medicos, which was established with the motto from a transition of knowing nothing in order to know something. It's me, Avika Parajuli, a third-year medical student from Kentucky Medical College, as the host for today's program. First of all, I would like to start with the rules. I would like to request every one of you in order to join by your good name. I request all of you not to interrupt the presentation with the unsolicited disturbances in between. I would like to tell you all that the questions and queries would be addressed at the end of the presentation. Without further ado, I would like to introduce our today's mentor, Dr. Manish Sahal. He has completed his MBBS. Sir, are you there?
Yes, I am there.
Thank you, sir. He has completed his MBBS from Universal College of Medical Sciences and MD from BPKHS Taran, and he is currently working in the UCMS in the Department of the Internal Medicine. He is always a humble person and always ready to help the students with their queries.
Excuse me, I completed my master's from NAMS, Kathmandu Veera Hospital. NAMS. It's not BPKHS. Yes, okay.
I'm sorry for the inconveniences caused, sir.
You can continue.
Thank you, sir. Now I would like to introduce our presentation, Mr. Sushil Dakal. He is currently studying fourth year in Universal of Medical Sciences. Are you available, Dai?
Yes, I am here.
Without further ado, I would like to start the program and hand over this floor to our presenter to the presenter of our today's session, Mr. Sushil Dakal.
Thank you so much, Vaini, for this wonderful introduction. And thank you so much, sir, for being here in program. So shall I start, sir?
You can start.
Thank you, sir. Sir, I'm presenting the case of Mr. Rajbhar, a 33-year-old male from Kapilvastu, Hindu by religion, married, construction labor by occupation, admitted on a UCMS in 2078, Phagun 30, and via emergency. And date of examination was 2078, Chaitra 3rd. Informant was his patient's wife, and history is reliable. With chief complaints of fever for 2 months, cough for 2 months, and loss of consciousness since 1 day. My history of presenting illness, according to patient's wife, my patient was apparently well 2 months back. Then he had fever, insidious in onset, intermittent type, mostly occurring at evening and night, associated with sweating. Temperature was not recorded, not associated with chills and rigor. Patient also had cough since 2 months, which was insidious in onset, productive, gradually progressive type, more during night, but without postural variation, yellowish to slightly brownish in color, mucoid type, non-foul smelling, non-blood mixed, about 2 to 3 spoonfuls per day. Patient also felt weight loss, which was evidenced by loosening of his previous clothes. He was taken to local clinic for treatment, but his symptoms did not subside. On the day he presented to UCMS emergency, he had loss of consciousness for 4 hours. His negative history, no history of abnormal body movement, fourth discharge from mouth, tongue bite, clenching of teeth, no history of blood in sputum, no history of shortness of breath, no history of trauma, no history of urinary incontinence and burning of micturition, no history of rashes, no history of diarrhea, vomiting, and GI disturbances. His past history is no history of documented similar illness in the past, no history of pulmonary TB, documented pulmonary TB, hypertension, diabetes, asthma, other psychological illness. His personal history, patient had a mixed diet. He was a smoker and alcoholic. He smoked about 5 to 6 cigarettes per day for 8 years. His pack years was 2 pack years. He consumed locally prepared alcohol, 24 grams of alcohol per 6 years. Sleep and appetite were normal. Bowel and bladder habit were normal. On his family history, patient has divorced though he was married for 8 years with 3 children. His children stays with his wife, but he stays with his father and mother. No history of similar such illness in the family. No history of any chronic diseases like hypertension, diabetes, asthma, and other psychological illness running in the family. Coming to his socioeconomic history, there are 3 members in the family living under the same roof. Lives in Kacha house with one bedroom and kitchen. Source of water is tap water and cooks in biomass fuel. Lower class according to revised Kupuswamy socioeconomic status scale. Coming to his drug and allergic history, no any non-history to any food or drugs. Immunization history, BCG vaccination scar was seen. On summary, a 33-year-old male migrant construction worker with complaint of low-grade fever at night and progressive productive cough associated with fatigue, weight loss, a night sweat for 2 months, presented to UCMS emergency with acute loss of consciousness.
So I think in this summary, after the summary of history, we can just stop for some time and we can just
okay, sir.
ask what are the differentials after this much of history? What are the differentials that come to your mind? A patient presenting with fever, cough of almost 2 month duration, along with altered sensorium of 1 day. So what are the differentials that we might be thinking after this? Because there are 3 diagnoses. One is historical diagnosis based on history, then is the clinical diagnosis after examination, and finally it will be a provisional diagnosis after investigation, our final diagnosis.
Yes,
so on
sir.
the basis of history, all the participants can participate. What are the things that are coming to your mind, and what are the points for and against those diagnoses?
Yes, sir. Since patient has fever, so I can think of infection. Since he has cough, any respiratory infection, and he has loss of consciousness, so acute loss of consciousness. So my diagnosis will be shifted towards neurological cause, sir. In that case, I'll suspect tubercular meningitis, sir.
Before that, let's go from simple. You have CORP 65 scoring. In CORP 65 scoring, confusion is one aspect of pneumonia. Pneumonia severity you do by CORP 65 scoring, and one aspect is confusion. So this loss of consciousness can be a part of severe pneumonia, and pneumonia can be part of tuberculosis. So before jumping into tubercular meningitis, it can simply be a chronic pneumonia which occurs in case of tuberculosis with altered sensorium as a part of CORP 65 scoring. And secondly, your diagnosis can be there. Any other provisional diagnosis which you want to keep, other participants can actively participate in this session.
Yes, sir.
So any other provisional diagnosis? Okay, I'm just putting in your mind that loss of consciousness can be part of confusion, which is seen in CORP 65 scoring of severity of pneumonia. And pneumonia of 2 month duration can be simple tuberculosis. Pulmonary tuberculosis can present. Second, your diagnosis, tuberculous meningitis, it's okay. Any other diagnosis?
Sir, bacterial meningitis, viral meningitis,
Bacterial viral meningitis we can keep in differential, but for and against will be the duration is 2 months for bacterial meningitis. It would be fulminant, means you would have other associated disability or comorbidity. By 2 months, generally they don't survive that much. So I want to go to hematology like Hodgkin's, non-Hodgkin's lymphoma. There are also type B symptoms which are fever. There can be compressive symptoms with mediastinal lymphadenopathy, which can produce cough, which can be non-productive, and there can be CNS mets of this lymphoma and leukemia, which can present with acute confusional state or stroke. So please consider leukemia, lymphoma, and lymphoma. Mainly, I'd like to go to lymphoma, Hodgkin's lymphoma, non-Hodgkin's lymphoma. Fever and cough can be part of type B symptoms. There is fever, weight loss, cough, which are similar to tuberculosis, and patient can present with loss of consciousness, which can be part of CNS meds. So lymphoma can also be a part of this differential diagnosis on the basis of history only. History, we can give simple pneumonia, we can give tuberculous meningitis, bacterial viral meningitis, we can keep lymphoma along with type B symptoms. So any other participants, if you have any other view or any other differential diagnosis bearing this history, you can express it, because after history the diagnosis can be anything, but just the points have to be familiar with the diagnosis. Anyone can put any input, else we'll move on towards the clinical finding. Okay, Sushil, I think you can move on to the clinical aspect.
Thank you, sir. Sir, am I audible?
Yes, you are audible. You
Yes,
can
sir.
move on.
So coming to general physical examination, patient is lying supine in bed with oxygen via face mask at 10 liters per minute. Patient is not cooperative and not oriented to time, place, and person. His GCS score is 7 out of 15. There is no pallor, icterus, clubbing, cyanosis, and no palpable lymph nodes. Coming to his vitals, his BP is 100 by 60 millimeters of mercury. His pulse rate is 109 beats per minute, which is regular, normal in volume. Atrial wall is normal, no radio-radial and radiofemoral delay. His respiratory rate is 30 cycles per minute. His temperature is 98 degrees Fahrenheit at febrile. His oxygen saturation is 86% with 10 liters of oxygen. Coming to respiratory examination, in inspection, upper respiratory tract reveals no specific abnormality, no nasal flaring, no deviated nasal septum, no nasal polyp, no nasal discharge. Tonsil was normal in size and not congested. There is no visible engorged pain and no visible pulsation, no tracheal deviation, no scar marks on chest, no chest wall deformity, no intercostal and subcostal indrawing. No use of accessory muscles of respiration. Nipples will present at equal level. Apical impulse is seen lateral to midline around the left nipple. Chest wall movement is bilaterally symmetrical and not restricted. Coming to palpation, trachea is central in position. Chest wall is elliptical in shape. Anterior-posterior diameter is 21 centimeter. Apex pit is palpable at left fifth intercostal space, 1 centimeter. Medial to mid clavicular line. Movement of chest wall is bilaterally symmetrical. Expansion of chest during inspiration is 85 centimeter and during expiration is 83 centimeter. Vocal fremitus was not heard. On percussion, resonant on percussion over bilateral long field. Upper border of liver dullness started from fifth intercostal space at mid clavicular line. Auscultation. Hind creeps over the right infraclavicular region, bilateral normal vesicular breath sound in rest of the long field. Coming to CNS examination, patient is not conscious, not oriented to time, place, and person. Sign of meningeal irritation like neck stiffness was present. However, Kernick's and Brzezinski sign was negative. Right pupil is 4 centimeter and sluggishly reactive to light, and left pupil is 2 centimeter and reactive to light. Illusion, delusion, hallucination, memory intelligence, speech could not be evaluated as patient was unconscious. On inspection, cranium is normal in shape, no unusual dilation of vessels. On palpation, no bony irregularity, no lesions and lump palpated. On cranial nerve examination could not be done as patient was unconscious. Motor function, muscle bulk. On inspection, variable muscle bulk of limb noted. On palpation, atrophy of limb noted, and tone hypertonic, clonus absent, power could not be assessed. Sensory examination couldn't be done. Sir?
Wait, I'd like to take to the motor examination part.
Yes,
Please
sir.
take to that slide, motor examination. Yeah, now you can see over here the On palpation, there is atrophy of the limbs, and in tone, it's hypertonicity. I'd just like to remind you about upper motor and lower motor neuron lesions. Over there, you can find that hypertonia is generally found in upper motor neuron lesion, and generally the atrophy and fasciculation is present in lower motor neuron type of diseases. I think you all agree with this. So why this person is having atrophy and hypertonia? These two things contradict over here. So the atrophy is due to his chronic muscle wasting due to chronic disease process, which he is having since 2 months. This is not a part of disuse atrophy due to neurological dysfunctions, whereas hypertonia is acute onset due to upper motor neuron type of lesion, which is responsible for his altered behavior and loss of consciousness. So this point has to be noted over here. Otherwise, you will be reaching to a different diagnosis like upper motor neuron and lower motor neuron lesion combined occurs only in amyotrophic lateral sclerosis, which is a motor neuron disease. So here we are not talking about a motor neuron disease. This atrophy is generally due to is chronic nutritional and chronic disease aspect. So I think you got this point.
Yes, sir.
And there is one more point before going to provisional diagnosis. There was on immunization, there is a simple note on BCG scar. So why is that BCG scar so much important? Can anyone give any clue about why the BCG scar is so much important in this patient?
Yes, sir. If BCG scar shows that he has been immunized against tuberculosis, so he might be less susceptible to tuberculosis infection, sir.
Yeah, you are right to some extent, but generally the BCG vaccination, it is not given to prevent tuberculosis. It is generally given to prevent extrapulmonary tuberculosis. Mainly central nervous system tuberculosis is prevented by BCG scar. Generally extrapulmonary. Pulmonary
Yes,
TB is very difficult to prevent. Generally the extrapulmonary tuberculosis and the sequelae is prevented by BCG vaccination. So if BCG scar is there, then we think that the vaccine has worked and he was able to contain the or limit the disease. So BCG scar is important over there. Now let's move on to the provisional diagnosis part.
Okay, sir. On provisional diagnosis, clinical meningoencephalitis secondary to infection, most probably tubercular in origin. Anatomical.
Okay, stop over here. In clinical meningoencephalitis secondary to infection. Why
Yes, sir.
meningoencephalitis?
Yes, sir.
Why not meningitis only? Why not encephalitis only? Why both?
Yes, sir. Since the patient is having fever, sir, and loss of consciousness, sir, so we would suspect for the CNS abnormality.
Because in meningitis, this loss of consciousness and altered behavior does not occur in meningitis. Meningitis, when there is meningismus, neck rigidity, high-grade fever, and neck rigidity, photophobia, these are the triads of meningitis. But when
Yes.
the brain parenchyma is involved, then loss of consciousness and seizure-like activities occur. So it is a combined entity of meningoencephalitis. Okay. Why
Yes, sir.
tubercular in origin? Why tubercular? Why not bacterial? Why not viral? Why not other? Clinically, why do you want to emphasize tubercular?
Sir, since he has fever and the specific pattern of fever is he has fever at night with sweating, and also he also has a significant history of weight loss, sir. So we would suspect this case for tubercular, and also
Okay.
he gives a chronic history of.
Yes. The third point is important. It gives a chronic history.
Chronic history, sir.
Means history, 2 months history. Short history, like bacterial, it will be fatal by 2 months. No one is going to survive with bacterial meningitis for 2 months. Viral meningitis and meningoencephalitis, generally viral is due to Japanese encephalitis, herpes simplex. They are also fatal, and the person will have sequelae such as comatose or fixed dilated pupil, hearing loss, or hemiplegia. So the duration, main thing is you told other things as clinical pictures, fever, cough, weight loss. Main thing is the duration, because fever, cough that can occur in bacterial meningitis secondary to pneumonia also, but the duration, main thing is the duration. Okay, the
Yes, sir.
anatomical sites,
Anatomical sites, lungs and meninges, sir.
nothing to explain over there. Etiology can be
Bacterial, tubercular, and viral, sir.
okay. Thinking about fever, cough, and loss of consciousness, we would like to keep the etiology on the infectious part only, as he is not immunocompromised. We have not kept fungal. If he was
Yes.
immunocompromised, we would have kept fungal
Fungal
and
also.
other parts also. Okay, move on
Yes,
to
sir.
next slide.
Thank you, sir. On differential diagnosis, we have tubercular meningitis, bacterial meningitis, viral encephalitis, encephalopathy. It may be a metabolic, hypoxic, hepatic, or uremic encephalopathy, cerebral malaria, and brain abscess, sir.
These are the differential diagnosis. In this differential diagnosis, intentionally, I left one space for you all to think about Hodgkin's and non-Hodgkin's lymphoma. That should always be included, because type B symptoms are in the type B
Yes.
symptoms. All are type B symptoms. So what are the type B symptoms in lymphoma? Can you name the symptoms? Type B symptoms are generally fever, drenching
Yes.
night sweats. People will be, all the clothing wearing and the clothes he wears will be wet in his sweat. There will be weight loss. There can be cough, sometimes due to mediastinal lymphadenopathy compressing the bronchus. So picture will be similar to tuberculosis, type B symptoms. Just see today type B symptoms of lymphoma, fever, weight loss, cough, night sweat. It will be almost similar, but in the clinical examination, you will be seeing lymph node, enlarged lymph nodes of cervical or mediastinal area, supraclavicular, axillary. There will be continuous expansion of lymph, enlargement of lymph nodes. So, encephalopathy and the tubercular bacterial viral we have discussed. Why encephalopathy? Metabolic, hypoxic, hepatic, and uremic. Why encephalopathy will have similar picture?
Yes, sir. In case of encephalopathy, there will be the specific pathology will be related to brain, sir. So since the patient gives a history of fever as well as loss of consciousness, so we can suspect if it is the case of encephalopathy, sir.
Okay, let me take it to the individual part. Like we can suspect with fever and cough is having pneumonia.
Yes, sir.
Okay, so hypoxic encephalopathy can be due to type 1 respiratory failure. If his pneumonia is worsening, then he is having hypoxia, which can lead to altered sensorium, which can lead to seizure. It can be a part of hypoxic encephalopathy secondary to his pneumonia. Second part, secondary to his pneumonia, he can have acute kidney injury, which will cause AKI, which can cause uremia. Because if you remember, CORP 65 scoring, there is a score for urea. So if urea is high, you can have uremic encephalopathy, which can lead to confusion, altered sensorium, and seizure. Now, third part, hepatic. Why? Is an alcohol consumer. So, alcohol consumer with infection. In infection, you can have lactic acidosis along with consumption of alcohol. That can also lead to metabolic acidosis, which can cause encephalopathy. And metabolic can be a part of this hepatic encephalopathy, uremic, or other metabolic abnormalities such as lactic acidosis due to infection. Now, why brain abscess?
Sir, in case of brain abscess, also we can have fever, sir, and loss of consciousness as well. So,
Now, how do you explain cough in brain abscess in this?
sir, we can also suspect from our chief complaint that he may be having a pneumonia as well. The infection might
Yes,
transmit
yes,
to brain as well,
yes.
which may lead to brain abscess and causing the typical symptoms which we have explained, sir, the fever and loss of consciousness, sir.
Yes. The main thing is it revolves around like is alcoholic. Alcoholic are prone to microaspiration. Mostly Klebsiella pneumoniae, they are prone to microaspiration. So if he has microaspiration, he has lung abscess or pneumonia, then that can have hematogenous spread and reach his brain, and alcoholic is a state of immunocompromised state. So that also we can consider. So what are the points not favoring cerebral malaria? What are the points against cerebral malaria? Because fever, these things are there. What points are not in favor of cerebral malaria?
Sir, weight loss, the history given by patient, and uh, uh, the address of the patient where he came from, and this is not a cerebral endemic area for cerebral malaria as well, sir.
And duration, what about the duration of the disease?
Sir, cerebral malaria is acute in onset, while the history given by a patient is insidious in onset. So we rule out the cerebral malaria, sir.
Cerebral malaria is fatal. It is insidious in onset in the geographical location, as you told. And in cerebral malaria, there will be focal symptoms of the brain, as this loss of consciousness is a global involvement of brain. So that also part is less likely to be in cerebral malaria. Other focal symptoms will be more prominent than generalized loss of consciousness. Loss of consciousness will be there, but focal symptoms will also accompany cerebral malaria. One, lymphoma should be kept in this differential diagnosis. So other participants, any other differential diagnosis that we have missed or you want to keep along with the points which are for and against, you can add. Any participants? Participants, you have to be participating because this is just a discussion forum. No one is going to tell you right or wrong. Okay, move on. Susit.
Okay, sir.
Move on.
Thank you, sir. Sir, coming to investigation. In investigation is in total count, differential count, neutrophil is slightly high, sir. Lymphocytes are low, and hemoglobin seems to be below the normal range, sir. In serum magnesium also seems to be high. In CCT of his head, basal exudates.
Go back. I'll just explain to you the individual parts, so it will be easier for you. Like in total count, just we'd like to see three things over here. Whether the total leukocyte count is increased or total leukocyte count is decreased, because neutropenia and neutrophilia both are part of sepsis. So I think that is not there. But whereas this neutrophil count, why the neutrophil count has raised in this investigation is, I think this is the investigation of first or second day. You was probably given some steroid in some emergency department. So what does this steroid do is it inhibits the peripheral chemotaxis of neutrophils. So there can be slight neutrophilia on this blood. So I think this neutrophilia picture without elevated total leukocyte count is a part of IV steroid, which was given on his way to where he reached our emergency. And that part is the platelet count. Platelet count, decreased platelet count is also a part of sepsis. So we can't see decreased platelet count over here. And coming to the hemoglobin part, the normal reference range is 13, 17, but generally we see from above 11. So below 11, hemoglobin is slightly low over here. And next one, we'd like to confirm the glucose part, because immunocompromised states are more likely for reactivation of pulmonary tuberculosis. Once you come into contact, the immunocompromised person are more likely to reactivate. So this random blood sugar also holds a specific significance. It is non-diabetic. Creatine part, he has no kidney issues because CKD, these are also immunocompromised state, and electrolytes and urea is within normal limit, means metabolic encephalopathy part is not there, especially uremic. Coming to calcium, magnesium and phosphorus, the electrolytes also can cause altered sensorium like hyponatremia, hyperkalemia, hypokalemia, hypermagnesemia. So this metabolic encephalopathy part is being ruled out from this investigation. I need to say, rule out very well. Okay,
yes,
now
sir.
Move on to next slide. This is how we explain the investigation part.
Yes,
okay, move on to the next slide.
On CCT of head, basal exudates with mild dilatation of bilateral lateral ventricles. On chest X-ray, yes, sir.
You can continue.
Okay, sir. On chest X-ray, ill-defined homogeneous opacity in right upper zone of lung. CSF analysis, TC 460, neutrophil 15%, lymphocytes 83%, protein 65 mg per dl, glucose 40 mg per dl, adenosine deaminase ADA 14 unit per liter.
Okay. So this, you can keep it over here. So this X-ray direct CT scan, it was a retrospective diagnosis. A
Yes, sir.
retrospective diagnosis means on the basis of loss of consciousness and findings of cough and fever of 2-month duration. Chest X-ray and CT scan was done at the same time, and it was easier to reach the diagnosis. So, what are the chest X-ray findings? Now, with all this investigation, our probable diagnosis will be almost tubercular meningitis. So, I'd like to discuss a bit on that. On the basis of chest X-ray, what are the findings that you would like to see in a chest X-ray suggestive of tuberculosis?
Sir, I will go for in case of tuberculosis, we'll have opacity in lungs, sir, with
Okay, it can be ill-defined, homogeneous or heterogeneous opacity. It can be in the right upper zone. In
Yes,
primary TB with the immunocompromised status, it can be in middle zone also, or it can be well-defined cavitatory lesion. Don't forget about the cavitatory
cavities.
lesion. There
Yes,
can
sir.
be cavitation, there can be calcification, which can occur especially in the apical part of the right upper zone. Then comes this Cohen's focus, Cohen's complex, Bull's complex. These are all the areas of necrosis, calcification, reactivation. So within that calcification, within that cavity, the tuberculous bacteria is contained, but later when immunocompromised status or malnutrition status comes, they get reactivated. So chest X-ray findings in there can be tubercular pleural effusion can be finding. And the finding can be simple enlarged hilar lymph nodes with scattered calcification around the lungs. So in chest X-ray, I'd like to ask if you are suspecting lymphoma, what finding will you expect in chest X-ray?
In case of lymphoma, sir.
Yeah. Any participant can answer, because lymphoma, if you see type B symptoms today, you will find it almost interesting and almost similar to tuberculosis. Generally, in lymphoma, the contiguous lymph nodes are enlarged. So you will preferably get hilar, mediastinal, or subcarinal lymph nodes. They are enlarged. So subcarinal lymph nodes enlarged will be the carina will be widened, or hilar lymph nodes will be enlarged. You can see enlarged hilum. Paratracheal lymph nodes is a bit difficult to see. So, can you turn to the city head part?
Yes, sir.
City head.
Yes, sir.
Okay, this was our city head finding. We wrote the positive findings. So, what are the findings you expect in a patient with tuberculous meningitis in CT scan? The findings suggestive of tuberculous meningitis in
Yes, sir.
CT head.
Yes, sir. Sir, in case of patient with meningitis, we can look for the hydrocephalus as well, sir. Dilated. Yeah, that can be seen on CT of head, sir, with mild dilatation of the brain of the cavity.
So mainly in city head, the main the finding of city head, basal exudates. These basal exudates are present of the meninges, which will obstruct the CSF flow, and they will cause or they will inhibit the reabsorption of the CSF, and they will cause dilatation of the ventricular system, and they can cause hydrocephalus. So probably this patient did have hydrocephalus, but bilateral lateral ventricles were dilated. So okay, let's suspect this patient has hydrocephalus and raised intracranial pressure. What will be the clinical findings which are suggestive of raised intracranial pressure?
Sir, clinical findings, we have fever, sir, first clinical findings, and loss of
triad of raised ICP,
yes, sir. Fever, headache, and neck stiffness, sir.
Okay, that
And vomiting.
Triad of meningitis, bradycardia, Cushing's triad, bradycardia, hypertension, and raised ICP. They come in that triad. So you have that vitals, why vitals is important. If there is bradycardia with a hypertension and raised ICP comes as a part of this. So let's go to next part, CSF analysis.
Yes, sir. Yes, sir. CSF analysis.
So what are contraindications to lumbar puncture?
Sir, contraindication to lumbar puncture are intracranial masses, sir, and immunocompromised state.
So mainly raised intracranial pressure,
Yes,
space occupying lesions, they are specific contraindication, or contraindication there can be bleeding diastasis that will not come in your part. So in this CT also there was slight dilatation of the ventricular system. So we can expect CSF pressure, the intracranial pressure to have slightly raised in this patient. So if we are suspecting raised intracranial pressure and we are doing lumbar puncture, then what is the specific technique that we apply to do lumbar puncture? Guarded LP, as soon as there is a guarded LP, you just don't release the trocar which is inside your needle. You just don't remove it completely. You will just pull it a bit outside and guard the needle, and the needle won't be fully exposed. The trocar, you won't take it fully out. You will just slightly remove it, and the CSF fluid will be dripping from the needle, that is guarded LP. If you are suspecting raised intracranial pressure and there is no contraindication to lumbar puncture, to a guarded LP, because in bacterial and tubercular meningitis, the opening pressure of CSF can be raised. So on the basis of this CSF analysis, what are the points suggestive of tuberculous meningitis and what are the points against tubercular meningitis?
Yes, sir. On the basis of this CSF analysis, first we can see lymphocyte is increased, sir, and protein is increased while the glucose is decreased. So we can suspect for tuberculous meningitis, sir. As well as ADA is slightly increased. So we can suspect for tubercular meningitis, sir.
So on the basis of WHO criteria, what is the gold standard for diagnosing tuberculous meningitis?
Sir, CSF analysis, sir.
In CSF analysis, obviously, for tuberculous meningitis, what is the gold standard in CSF to tell it is a case of tuberculous meningitis? It is gene expert, like you do a lot of gene expert on sputum, but WHO tells that this gene expert of CSF has almost sensitivity and specificity above 90%, so that is very sensitive. So always when you do a lumbar puncture, just remove the CSF and send it for gene expert. Sometimes the adenosine deadenase may not be raised, but the gene expert finding will be significant. As you told, the total count is not much raised. That is suggestive of tuberculosis, meningitis. Then this neutrophil lymphocyte predominance. Then protein is expected to rise more than that, but it is just slightly only raised, so it is also suggestive. Glucose is on the lower side, so it signifies bacterial. It can be bacterial or it can be tubercular. ADA above 10 is significant. So we in this patient we tried for gene expert, but both gene expert in Kutala and Bhairava both were not working, and he was not affording for doing gene expert on private basis. So we could not send a gene expert for this. But for you, you can send gene expert. Nepal government has centers where gene expert in CSF is done free of cost. So CT scan, chest X-ray is suggestive of pulmonary tuberculosis. CT head is suggestive of basal exudates and brainstem meningitis, which is also suggestive of bacterial or tubercular meningitis. CSF is suggestive of tubercular meningitis. Now let's move on to next slide.
So ABG analysis, we have pH 7.36, partial pressure of oxygen 68%, partial pressure of carbon dioxide 42%, bicarbonate 22, liver function test within normal limits, sir. PTINR 12 of 1.1, thyroid function test normal, sputum acid fast 1 and 2 negative, sputum gene expert positive, sir.
Okay. So this pH, we just want to confirm that there is no type 1 or type 2 respiratory failure. So ABG was done to exclude encephalopathy. Liver function also and PTINR also done to exclude any hepatic cause of encephalopathy. Thyroid function test to exclude any cause of myxedema coma. That is also there. So in this patient, X-ray and CT scan was done on the same day, and the search for tuberculosis was done on sputum and CSF simultaneously. And the sputum gene expert and CSF analysis came a day earlier, whereas the sputum gene expert came 2 days after starting the ATT, but the sample was sent before the starting this anti-tubercular drug. So what will be your final diagnosis in this case?
Sir, final diagnosis will be tubercular meningitis, sir.
Tubercular meningitis, or you can take pulmonary tuberculosis with disseminated extrapulmonary tuberculosis in the form of meningitis, or simply you can tell tubercular meningitis. So what will be the take home message from this presentation if you have to tell in 3-4 lines?
Sir, the take home message from this presentation will be the symptoms of tubercular meningitis, sir. Fever, which will be chronic, which insidious, which will be insidious in one set, which will progress in chronic manner, sir, and loss of consciousness as well, sir. And we can have different we can have differential diagnosis, the tubercular meningitis, different encephalopathy as well, sir. And for the diagnosis, we have to go for CBC, RFT, LFT, and CT. We also could know about the lumbar puncture as well, sir. But these are some of the take-home messages, sir.
I'll summarize you in short. Always think TB. Tuberculosis, it can present as anything. Whichever symptom, if anyone asks you a differential, TB can always be kept. So always think about extrapulmonary tuberculosis also. If features are suggestive of pulmonary tuberculosis, the complications can be extrapulmonary tuberculosis. It can be meningitis, it can be pericarditis, it can be gastrointestinal TB. So think about complication and extrapulmonary tuberculosis. Next is always do a lumbar puncture in a patient who has fever with altered sensoria, and send a full panel analysis for bacterial, viral, and never forget tubercular. And if possible, send a gene expert in CSF to rule out tubercular meningitis. And finally, the third part will be in any patient presenting with fever and cough, sputum AFP negative does not signify that person does not have tuberculosis, because TB can be sputum positive and sputum negative. So always go for gene expert. Means we could have lost this case if we hadn't done sputum gene expert. Sputum AFB was negative. Okay, let's go to alternate diagnosis. Then we would have missed the case. So in a case suspected of pulmonary tuberculosis, after sputum AFB, always do a gene expert to reach a conclusion that this person does not have TB. In a patient with altered sensory, always do a lumbar puncture and do a full search for ADA and sputum ADA and gene expert of the CSF, and always look for extra pulmonary manifestation of tuberculosis in patients suggestive of pulmonary tuberculosis. So anything else now? It's open to questions. Okay, Sushil. Now
Yes, sir.
anything else?
Sir,
It was
I
a
think,
good presentation.
yes,
You
sir.
did good.
Sir,
you people have. Yeah, you can take.
Some points about the treatment as well, sir.
Okay, if you want to know about the treatment, then generally the treatment you have to first you will do is there is no category 1, category 2 or category 3 nowadays. Generally for treatment you will first like to do the LFT and RFT. LFT and RFT with that's normal. Then generally now they tell that 2-HRJD, which is isoniazid, rifampicin, pyrazinamide and ethambutol for 2 months. That is your intensive phase. Then finally you will go into the continuation phase. Continuation phase can be of 7 to 10 months duration, and it will consist of HRE, means isoniazid, rifampicin and ethambutol. This is for almost all extrapulmonary cases of tuberculosis. So 2-HRJD plus 7 to 10 HRE. HRE is the treatment of choice for this extrapulmonary cases. Sometimes the treatment can be extended beyond 12 months also in context of Nepal's guideline, not WHO, Nepal's guideline. If you see the guidelines, sometimes the treatment, total treatment is of 2 and 10, 2 months intensive phase, then 7 to 10 months continuation phase. The 10-month continuation phase can be extended further. So it will extend beyond 12 months. In that case, you have to send to a specialist working in TB center so as to check the sensitivity and specificity for second line drugs, drug sensitivity testing. Streptomycin is not there, and another aspect is steroid. Dexamethasone should be given, and dexamethasone should be given in tapering order. We can give it up to 8 weeks duration. And the third aspect, which we haven't found in this investigation, is always rule out the serology, seropositive status like HIV. Because if the patient is HIV positive, then it will depend upon the CD4 count and this opportunistic infection. So there is a time factor before initiating ART and before initiating the anti-tubercular drug. So always rule out seropositivity. And in case of pregnancy, another entity is pregnancy. Pregnancy, you can go with same drug as given by our Nepal guidelines. And other supportive treatment will be with pyridoxine. You can give 10, 20, and if patient is chronic alcoholic, you can increase the dose up to 100 mg. And it's always better to keep a PPI because these drugs are prone to cause your gastric irritation. Then counseling of the patient regarding sequelae, there can be sequelae and improvement will take time. And regarding the complications about hydrocephalus and simple complication, whenever you start anti-tubercular drug, always counsel the patient that its secretions are going to become orange color due to rifampicin. Otherwise, they will be very much worried. Urine is getting orange colored, the saliva, its bed sheets are getting orange tints, and they think it is hemoptysis or blood in the urine. Counsel about this discoloration due to rifampicin. Then other complications you have to manage about gout and joint pain, which are related to pyrizinamide, then ocular toxicity is due to ethambutol that you have to monitor, and always monitor liver function test because ATT can cause acute hepatitis. So monitor liver function test on the baseline 14th day after completion of initiation phase, intensive phase, and after completing the therapy. This much will be enough for your management.
Thank you so much, sir. Finally, we are at the end of the presentation. So I would like to hand over this platform to the host. Over to you.
Thank you so much, Dai. Sir, there was one question in between. I'd like to address that question. Why the vessels of the head is examined?
I couldn't get the question. Why
the vessels of the head is examined?
Why the vessels of the head are
Examined.
examined? Can you type the question? I didn't get the question. Vessels of the head are examined means what do you want to know?
I think the question is not clear in itself, and it's asked on the basis of the presentation.
Vessels of the head. Sushil, did you get the question? If you can clarify the question, it will be a bit easier to answer.
Looking for the
Why
question,
the
sir.
vessels of the head examined? Yeah, I can see here the question. Vessels of the head examined means on examination we are not examining the vessels. Just where did this question arise? It is just that the brainstem meningitis, there is basal exudates at the base of the vein. So it is not the vessels. It is involving the this arachnoid and pia matter. So it can inhibit the absorption of the CSF, or it can block the flow of the CSF. So in that part, the hydrocephalus occurs. That is the pathophysiology of hydrocephalus in tuberculous meningitis. So for that cause, only the vessels of the head can be responsible. And another question is,
yes,
is BCG vaccine preventive for extrapulmonary TB in adults? So this is a good question. There is a question telling that when do you get BCG vaccinated? When the BCG vaccination is given, that will provide you the immunity for protection from extrapulmonary tuberculosis. Generally, if it is given before the age of 10 years, generally in our setup, it is given after birth, that protection will be for almost 10 to 20 years. But if given later in life, that can be extended further. So that's why while doing a Montauk's test in our setup, we generally, that Montauk's can be due to BCG. If you are already given BCG vaccine and if you have that antibodies to PPD, then BCG vaccine this Montauk's test can be positive. So in adults also BCG vaccine can be given that can prevent from extrapulmonary tuberculosis. The BCG vaccine which is given at birth, the immunity can wane with time, and in adulthood also BCG vaccine can be given, which is a protocol in developed countries where the people coming from third world countries are given added BCG vaccine. So any other questions?
I think there are no other queries, sir.
Okay, thank you so much, everyone. Now I'd like to proceed on. Ayesha Didi, can you open the token of love? Thank you so much, sir, for such an informative session. It was quite an interesting and with a lot of detailed information about the topic tubercular meningitis. Now I'd like to hand over the floor to Dr. Manish Sahal, sir, for a few words about the session.
Okay, I'd just like to tell it should be interactive, like we are telling something, just 2-3 points, like if we are telling something, it should be interactive because only a single presenter, it won't affect. So what are your mistakes that is to be corrected? So any thought It can be very awkward, it can be very wild, it can be not related to the context, but input should be there if you are doing these sessions. Your mistakes has to be corrected. Thank you for this token of love. Main thing is it should be a discussion session. So you have to put your input over there, and points for and against should be discussed. That would have been more better than a mentor and a presenter telling the things in between after history, after clinical examination, or after we have to be more interactive. That's one input from my side and nothing more. And thank you for the opportunity. I'm always ready for these sessions. Whenever you need me, you can come up to me. Okay, thank you.
Thank you so much, sir, for your kind words, and we will be looking forward to have you in the upcoming session also. Now, I'd like to give the floor to Sushil Takaldai for his words.
Hello, am I audible?
Yes, sir, you are audible.
Thank you, Abhigya Baini. First, I would like to thank our Dr. Manish sir for always being there, for always guiding us, for conducting this webinar so successfully, and for guiding and motivating us. I would like to give my sincere thanks to the team of the Grey Medicos for conducting this program as well. And we are still in the phase of learning, and we have been learning. I would like to end my speech. We are again giving a lot of thanks to our sir. Thank you so much, sir, for being mentored into this program. Thank you. Over to you, Benny.
Thank you so much, Dai. It was wonderful hearing you. Now, I'd like to hand over this floor to Ravi Basyal Dai for the vote of thanks.
Good evening, Manish sir. Good evening, everyone. Thanks a lot, sir, for giving us a valuable time and letting us to know many things. The webinar has boosted our knowledge. From the entire team of Grey Medicos, so we'd like to thank Dr. Manish Dahal sir and the presenter, Mr. Sushil Dakal sir. We will be doing webinar and next. We'll be coming with next webinar soon. With this, I would like to thank everyone. Thank you. With this, we can end the program here.
Thank you so much, Dai, for your kind words. Now, we are finally at the end of the session. Thank you so much, everyone, for being here. Now, I would like to request thank you so much, sir. Thank you so much, Dai, and we hope this would be conducted in upcoming days too. And we all are looking forward to see you all in the upcoming days also. Now, I'd like to request the host to end the meeting.
Thank you, sir.
Thank you so much, everyone.